So in metastatic melanoma, testing for BRAF mutation, again, is very important up front so that we know if our patients have the option of being treated with targeted therapy. All of the currently approved therapies in the metastatic setting have actually been approved in the first line. So BRAF-MEK inhibition with, again, dabrafenib, trametinib, vemurafenib, cobimetinib, and now encorafenib, binimetinib. All three combinations have been tested in the first line setting. Nivolumab single agent, ipilimumab single agent, pembrolizumab single agent, all approved in the first line setting. And then we have data from nivolumab in combination with ipilimumab where we have some improvement in PFS, a modest improvement in OS, and again, a combination that's approved in the first line setting. So technically, all of the data that we have at our disposal is really what do you start your patient, what would happen to your patient if you started with a therapy first. We actually don't have really great data about what you should do in the second line, and I think that is actually where a lot of the confusion and a lot of the kind of debate on what you should start first comes from. What we do know is targeted therapy is highly effective and it works very quickly, but also has a limited duration of response. What we know from immunotherapy is that you have potentially lower response rates if you start with single agents. However, almost every response that you get with immunotherapy tends to be more durable, if not very durable. So if you can achieve a complete response, for instance, with immunotherapy, those responses look like they're, durable for many years. Partial responses seem to be durable, but some of those patients can still progress. So again, we discuss all of those aspects with patients. We generally err on the side of of using immunotherapy unless the patients have some reason to start with BRAF targeted therapy first, such as a need for quick responses. We say this knowing that sometimes those patients that need quick responses have high LDH levels, have a performance status issues. Those are the patients that actually have the shortest PFS with targeted therapy. So if we use targeted therapy in the first line, we're already kind of using it as a strategy to try to move to immunotherapy as quickly as possible. The last point that I will make in this setting is there is some really convincing data in brain metastases that immunotherapy with the combination of ipilimumab and nivolumab is the most effective approach that we have for those patients. So if those patients have untreated brain metastases, we highly recommend the use of ipilimumab and nivolumab. Targeted therapy is effective for those patients, has intracranial responses that's as high as 58%, but those responses in the brain seem to be a lot less durable. So again, for that particular population, I think the choice is kind of swinging significantly towards using immunotherapy combination up front.